Everybody, I'm Wojtek Kalowski. I'm here professor at Telfer School of Management. And I would like to welcome all of you on the Telfer Health Transformation Exchange event. And how we will start, I will I will ask Dr. Michael Funky Funk from TOH, who is co-leader with me of the Transformation Exchange, to introduce our today's speaker, Dr. Eric Isselbacher. Please, Michael.
We were expecting a little few more people coming, but we decided we'll start. It's great to have Eric here with us. You know, this relationship actually started online. It sounds like a dating agency, but we never really met till this morning. And I feel like over the course of the day, like we've known Eric for 10 years. It's such a kindred spirit. And I think that's in the space of health innovation and transformation, there are groups of people reaching out across the country to try and connect with each other who have this kindred spirit to see how innovation can happen in health. And his story today will be, I'm sure, very informative for us. Eric is a cardiologist. He's associate professor at the Mass General. For those who don't know, the Massachusetts General Hospital is the #1 hospital in the US, rated for several years in a row by many agencies. It's 1,000 beds, it's over 200 years old. So to innovate within a 200-year-old top hospital is challenging. So we look forward to seeing how he tackled that issue. He's founder and director for the Health Transformation Lab, has been instrumental in actually creating larger groups of people interested in transformation, has worked across other agencies as well. So again, without further ado, I'll ask Eric to share his experience as we asked him to with us today. Eric?
Well, it's certainly a pleasure to be here. It's my first trip to Ottawa. It's a lovely city, and I'm very grateful for the invitation and also the opportunity to meet and talk to like-minded people who are interested in trying to improve healthcare delivery and healthcare for our patients. So I've got no disclosures to make. First off, of course, I'm from the United States, so when I talk about problems with our healthcare delivery system, I'm primarily talking for some of the early part of the talk about problems with the US healthcare system. But many of the issues around innovation really, I think, cross the border. But I think we have fundamental differences in the drivers of healthcare in the two parts of our continent. So in the United States, healthcare costs are rising at a rate that really is unsustainable. If you take a look at the costs over the last half century, you can see they've nearly tripled, from about 6% of GDP to close to 18% of GDP, and that kind of growth is simply unsustainable. Now you could say, well, healthcare costs more these days because we've got all kinds of new devices, new imaging studies, new therapies, and therefore, of course, it's going to cost more. So why are we so worried in the US? Well, the fact is, if you compare the healthcare spending in the United States to other Western countries, you can see how we're really off the curve. The United States, oops. Let's go back here, sorry. The United States here at the top in yellow, you can see how we compare to, say, Canada. But if you come down to Japan and New Zealand, they're really only about 8% of GDP when we're up at about 16 to 18% of GDP. So clearly, it's not necessary to be spending so much on healthcare. Now, the other way you could frame it is maybe we're just getting more for our dollar in the US. We're simply delivering better health care, and we like to get the Cadillac of everything in the United States. But if you take a look at this data here, you can see that, in fact, we're not getting more for our dollar. So the US is spending about twice as much per capita as other Western countries. And yet if you look at quality in terms of average life expectancy, we're not getting anything better. In fact, we're actually on the lower end of the curve. So it's hard to say that we're getting more for what we're spending. And if anything, we seem to be getting less. So all the more reason that we have to try to do something to tackle this problem. Now, the Institute for Healthcare Improvement in 2008 introduced the concept of the triple aim with guiding principles for how we should try to fix healthcare delivery. And what they recommended was improving the patient experience, both quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. So better quality, lower cost, basically driving the value equation to provide more value in healthcare. So all of this is great to talk about. I don't think anybody could disagree with the goals, but these are not easy to reach. And in fact, if you take a look, we're far away from achieving these goals, even 8 years after they were articulated. We have high costs, as I just talked about. We've got limited quality. In addition, though, we still have a system of episodic care. You see your doctor once or twice a year, and the rest of the year you're not communicating or connected. You're on your own to try to care for yourself or figure out what's healthful. We've got a fragmented healthcare delivery system. We've got doctors that aren't communicating with hospitals, hospitals that don't talk to one another, hospitals that don't talk to pharmacies, insurers that don't talk to anybody, and this is not a good way to deliver care to our patients. And we certainly have misaligned incentives in the United States, fee for service. The more care you deliver, the more surgeries you perform, the more diagnostic imaging studies, the more you earn. The faster you are seeing patients, the less time you spend with them, the more you earn. None of that is in the patient's interest, but that's what's driving our system. We have lack of patient engagement, lack of family engagement. This is international. We've got to get our patients to take more responsibility for their care, and to do that, we need to engage them more. We can't see them once a year in the office and expect them to do all of this on their own. And then there are a host of other problems that we won't get into today, but we can all agree we're far from solving the problem. So the bottom line is we have to change the guiding principles of how we deliver care. In the United States, we have a volume-driven healthcare system, fee for service. The more we do, the better. That clearly isn't working. And we need to move to a value-driven healthcare system where we focus on quality, outcome, patient satisfaction, rather than the amount of care delivered. So how are we going to do that? Well, clearly in the United States, that's going to require government stepping in to try to help the system move in that direction. The fact is Obamacare was the first step in that direction, and it was just really a very small step in that direction. And yet it caused a political fallout in the United States that still resonates today. In fact, the Republicans all want to reverse Obamacare, revoke Obamacare, really when it's done very little in terms of changing care delivery. But they're all horrified that we're doing anything to move in that direction. So given that experience, I don't see that comprehensive reform is going to be coming anytime soon. You know, maybe the candidate on the left might be inclined that way, but we'll never touch it because it's a political hot button. And this guy on the right, I don't want to get started, but he's not going to be doing it either. So if the government isn't ready to step in yet, we're really left with healthcare institutions, either large healthcare delivery systems or individual hospitals trying to tackle some of these problems on their own. If there's any hope of improving the system we have now, I think it's going to be up to us as the delivery systems. But I don't think we're going to be able to simply put more money into the system because there's no money left. So we're not going to be able to hire more providers or expand our services. We're going to have to find other ways of doing it. Now, what the hospitals have done over the last decade is simply tried to use incremental change, primarily by making physicians work harder or literally run faster to try to make the system more efficient. But that's not tenable anymore. Doctors are strained to the limit. The other approach hospitals have taken is to squeeze the budget. And squeezing the budget isn't going to be possible any further because we're squeezed as tight as we can. And this is all pretty painful. And we're at the limit, so this isn't going to do it either. So recognizing that, I think all the hospitals and health systems have now come around to say we have to innovate. Innovation is the way we're going to get there. So innovation has become the new black. In hospital parlance right now, everything is about innovation. And the fact is we actually are pretty good at innovation in medicine. As a cardiologist, I can tell you we're outstanding at innovation in terms of cardiovascular therapies, cardiovascular science, and technology. Just look at what we've done in cardiology. For instance, the first catheterization procedure was in the 1950s. That was remarkable. And since then, we now have intracoronary drug-eluting stents to fix every blockage that people have. That's fantastic. We've got high-tech imaging to look at the heart, the arteries, the valves. We don't even have to do invasive testing anymore. We've got cardiac surgery, of course, and robotic cardiac surgery to do really nice, minimally invasive work. We've got implantable cardiac defibrillators so that patients can be essentially monitored all the time, and you can intervene instantly to save a patient's life. Not only do we have valve surgery, but we have minimally invasive valve implantation procedures now, which are a big advance. And then finally, we have this thing called the left ventricular assist device, which is almost like an artificial heart. When the heart can't beat anymore, we can sustain the patient in the heart. These are all amazing advances. So in terms of technology in cardiology, we get an A. In fact, I would say we get an A+ with things like that. So that's the upside. But the real question is, when it comes to healthcare delivery, are we doing the same kind of work in healthcare delivery? And I would say, well, let's take a look at how we're doing on that front, comparing the 1970s to the current decade. This was a computer in the 1970s. It was very big and didn't have all that much computing power. And today, a computer that's way more powerful sits on your desktop, or better yet, in your hand. So that's a big advance. This is a doctor in the 1970s, and as you can see, Marcus Welby is outfitted with a white coat and a stethoscope. And now in the 2010, doctors are outfitted with a white coat and a stethoscope. So really no change there. This is an exam room of the 1970s. Basically, you've got the exam table, you've got something to look at the eyes and the ears, a blood pressure cuff, and that's about it. And this is an exam room in the current decade. Everything is identical, except now we have a computer on the wall so that the physician can turn away from the patient and enter information into the electronic medical record. But otherwise, the tools in the exam room are no different today than they were in the 1970s. So in terms of advances in healthcare delivery, a doctor-patient relationship, really not much has changed. Now compare that to other industries and what consumers have come to expect, the way they interact with industries other than healthcare. If you want to make a dinner reservation, you don't pick up this thing called the telephone anymore. You simply use your OpenTable app and you make a reservation that way, right? You want to get on an airplane to take a flight, you don't get one of these things anymore. Do you remember the days when you used to have to actually go to the travel agent and get your ticket, and you better not lose your ticket because that's your ticket? Of course, we don't do that anymore. You make your reservation online and you have an electronic ticket. When you go to check in, you don't stand in line. Well, at Delta you might, but you don't stand in line anymore. You'll check in at a kiosk, or better yet, you check in on your phone. But when you go to the doctor's office, you stand in line to check in the old-fashioned way. So we're really not keeping up with other industries at all. And in fact, it's pretty embarrassing, the slow pace of change in healthcare delivery. So the goals of care for us should be clear. What is it that the IHI triple aim is great to talk about, but specifically, what are the challenges that we need to talk about? We should have automated systems rather than manual systems. We need to have integrated care versus fragmented care. We need patient-centered care rather than provider-centered care. I often like to talk about the fact that if a patient gets sick, if a patient has symptoms and wants to see me, I can't see the patient because my schedule is full of seeing patients for their annual visits. Those patients are well, and they don't really need to see me, but they're the ones filling my schedule. So the sick patient, I have to say, sorry, I can't see you. You need to go to the emergency room. There's something wrong about that. I should be seeing the sick patients, and the well patients, they could be checking in online or with virtual visits where they could be using devices at home to see that they're well. But I'm busy taking care of the well patients and sending the sick patients to the emergency room. We should have continuous care rather than episodic care, ways to communicate and monitor patients between visits. We certainly need to have incentives that favor the right kind of care, appropriate care at the right time, rather than a volume of care in the United States. And it should be evidence-based care, and if there's evidence that we should be doing something, we need to make sure that we're doing it. And if it means the EHR needs to tell us your patient needs to be on a blood thinner for atrial fibrillation, that is a good use of the EHR, and we certainly should be using that. We shouldn't be leaving it up to providers to make these decisions alone. And then finally, we should have standardized protocols and checklists and not leave it to the providers to figure these things out on their own. When I fly back to Boston, if I had the choice of an airline where the pilots had a checklist versus a pilot could just kind of do the takeoff protocol however he or she wanted, I know which airline I would choose. And we should be doing the same thing in medicine. So there's no question that there's a huge opportunity. Innovation is desperately needed, but the opportunity is there for us to improve the quality of care, reduce the cost of care, and ultimately improve patient outcomes and patient satisfaction. So that brings me to my story of innovation at the MGH. How did I get involved in all of this? Well, for the past 10 years, I was the Associate Director of the Heart Center at MGH, and really the purpose of the Heart Center was to change and improve the way we delivered care to our patients. So, terrific platform to introduce change. And for the first few years, things went very well. I led a variety of innovation efforts and change efforts that went well, and I was feeling very good about my job and my career. And while some of the things were successful, as the years passed and we tried to do newer, more innovative things, a lot of these efforts started to stall. Managers weren't so interested anymore in experimenting because things were pushing a little too hard, and they were really busy with their day jobs. And then I found that some of the innovations we tried to introduce met with frank resistance. It was too threatening to people when we started to try to change the way they were used to doing things. And this is where things became really tough. And I couldn't get innovation to move any further. And when you think about it, as Michael said, it can be very tough to innovate in an institution like Mass General. If you think about our institution in particular, nothing stifles innovation like being the #1 hospital in the country, because it tells the president, whatever we're doing is perfect, don't change a thing. What will the trustees say if you were #1 and you went and messed with it? Don't change a successful formula. So that was the first strike against us. The second was we were financially stable. There was no burning platform. If we were in the red, we might need to do something, but we weren't. So leave everything alone. We had high patient demand. So yes, we're competing for patients, but the fact is there are plenty of patients coming in. So again, we don't need to do more to change that. And then finally is the kind of statement that we would hear over and over again, we're doing well, why change, why be disruptive? So that's why people would see me coming down the hall and they'd hold up their hand and say, you know, I don't want to talk to this guy. He's going to keep saying we should do things differently. So that was kind of the challenge that I faced. But I realized, yes, MGH may have a great track record, and they might have led us to be #1. But there's no institution that's too big to fail. In fact, everybody can learn from the experience of Kodak with a tremendous history, but in the end, it looked to its past and when it was unable to adapt to the future, and now the company is basically gone. But it wasn't necessary, and I didn't want to see that same thing happen at Mass General. So my view was that we had a particular challenge at MGH, which was how do you innovate in a company that's already very successful and people aren't seeking innovation and aren't welcoming the innovation. So to try to figure this problem out, I decided I need to leave the institution and go elsewhere to gain knowledge and insight that I might not already have. And a colleague of mine had gone up, named Jim Kim, had gone up to Dartmouth and became president up there. And he brought the Tuck School of Business and the Dartmouth Institute for Health Policy together to create a new program called a Master in Healthcare Delivery Science, to really try to focus on how is healthcare being delivered both nationally and internationally, and what can we do to make it better. So mid-career professionals were brought in as students in this, and it launched in 2011, and I went up to Dartmouth to try to learn in this program, and it was a great program. So you can see all these happy, thoughtful students in the class. And it was great, and I learned a lot, but I was still faced with how am I going to take the lessons I've learned and go back to MGH and do anything different. If I go back to my same job as Associate Director of the Heart Center, it's still going to be the same challenge that I faced initially. So then I met this guy named Chris Trimble, who's a professor at Tuck, and he's specifically interested in innovation. And in fact, he wrote this book called The Other Side of Innovation, which emphasizes the fact that the ideation is actually the easy part in innovation. It's the implementation that's the hard part. And his focus really is how do you make sure you implement the good ideas that come out of your team. In addition to that, though, he began to get interested specifically in innovating within a successful company. Startups, it's easy to innovate because that's what they're built for. But when you're a successful company, there's a lot of resistance to innovation. And Basically, what he talked about is that a successful company has what he called a performance engine that basically is driving its production, driving its success. And performance engines are specifically focused on today's customers, today's competitors, the routine operations that have been honed and are very efficient. There are familiar tasks and workflows for the staff. It's focused on efficiency. It's focused on accountability. Everybody's being measured and monitored and accountable. And ultimately, it's there to generate revenue. And that's a very traditional and well-functioning system. But that's not a system of innovation. If you take a look at what an innovation team is focused on, it actually doesn't jibe very well with the performance engine. Innovation is focused on new customers. Innovation is focused on future competitors. How do you protect yourself? Like Kodak, how do you protect yourself against what's coming down the pike? It's not routine operations, but novel operations. Instead of the familiar, you're experimenting. Instead of efficiency, you're really talking about accepting inefficiency of experimenting and innovating. And accountability turns into taking risks. And then finally, instead of generating revenue, you're actually asking the institution to make an investment. So you're not talking about how much profit are you going to bring in, it's how much are you going to cost me when you're doing these new things that you say are so important to do. And this is what then makes it so challenging to innovate in a successful company. So Chris talked about exactly why innovation is destined to fail with the performance engine. So firstly, you're going to threaten those who created or are personally invested in the current systems. They're successful at what they're doing. They got a great job. Don't threaten my position and my job. If you try to get your staff to tack innovation onto what they're already doing, that's going to overburden them. And they might be able to do it for a little while, but it's not sustainable. And it's usually going to be their lowest priority in terms of their work. Experiments are going to decrease efficiency and increase costs, as I mentioned. And then there'll be this tension. If you try to do the two things simultaneously in the same group, there's going to be a tension between the people who are doing things the old way and the people who are doing things the new way. And it's going to be very hard for them to get along and not be jealous or angry, etc. And then finally, as we saw at MGH, when finances get tight, the first thing that's going to get cut is the innovation budget or the innovation staff. It was kind of remarkable. The hospital actually put innovation on its strategic priority list 3 years ago, and then the next year when budgets got tight, the innovation budget got cut. So it's on their strategic priority, and it was the first thing they cut. So what kind of message does that send to the staff, and how successful are they going to be with innovating that way? So what Chris Trimble proposed was that if you're trying to innovate in a successful company, don't do it within the performance engine, but set up a separate innovation team. So on the left is the performance engine, which has its typical departmental leaders, managers, and staff. And then on the right is a separate innovation team that's dedicated to innovation. So it's got its own budget and its own full-time staff who are focused solely on innovation. And they've got a leader who's driving that. Now, this wouldn't work if this were all there were in the model, because basically they have two separate companies. And so you're not going to drive innovation into your performance engine this way, so you have to be connected. One way to be connected is to have a part-time staff, a shared staff, mostly in the performance engine, but who spend part of their time in innovation, and part of their salary comes from innovation. So they answer to both leaders. So they're answering to the regular performance engine leader and also to the innovation leader. That's still not enough. You have to have direct communication, direct partnership between those people and the innovation staff. So this is the model that Chris proposed. And it looks very good on paper. Obviously, it's a lot harder to implement, but this made a lot of sense to me when I was up at Dartmouth. And most importantly, it gave me something new and different that I could try, that I could bring back to MGH and propose this, because it wasn't working the way it worked before. So with this in mind, oh, actually, I should just finish and say, so the way this would work is an idea would be proposed, and then you would have iteration and experimentation within the innovation team. Once that idea was kind of fleshed out and worked well, only then would it move from the innovation team over into the performance engine and be adopted. So they wouldn't be experimenting. Once we figured it out, we'd then pass it off to them. And that's the way the two would work. So we would take the risks, they would do the implementation. And one other thing that Chris talked about, which I think is important, is how to present this to your organization, because there's really a spectrum of innovation. That word gets overused. So where does this fit in the spectrum of innovation? Well, as you can see on the left-hand side are these things called small projects that involve part-time staff, so that the staff can just spend a little bit of their time trying to do some of these things. So, for instance, introducing a checklist into your operating room doesn't require hiring a full-time staff. People can do this part-time, introduce it, and make it successful. So that's the left-hand side of the curve. On the right-hand side of the curve are things that involve full-time staff, and on the far right are large projects. So things that are high-risk game changers, such as opening a new line of urgent care centers. That requires a big capital investment, a big commitment on the part of the institution. That decision is going to be made and led at the highest levels of the hospital. So you've got the kind of the staff on the ground level on one extreme, hospital leadership on the other, but there's something in between here. Now, Chris calls these overlooked opportunities. I don't know that they're overlooked so much as they're underserved. People aren't really focusing their time and attention on these. And he gives an example of a small team that redesigns and then delivers improved care for patients with chronic complex conditions. And that's the opportunity for a team that's well connected with those in the performance engine, but has enough staff and budget resources to carry out these projects. So with these two lessons, building an independent innovation team and focusing on the middle of this curve, I felt that I could take these messages back to MGH with me. So I left Dartmouth, came back to Boston, and I thought, maybe I'll go meet with the president of the hospital and the vice presidents and give them my PowerPoint presentation, because that will convince them to do this. But at the same time that I was thinking about that, the hospital announced big budget cuts, 5% cuts across the board. Every department had to cut 5%, period. I was surprised they didn't even choose which departments, some who were generating a lot of money and some who weren't. It was 5% across the board, so everybody had to cut. That's a terrible environment to walk into a president's office to say, could you spare a few $1 million to set up this new shop? Because whether he wants to or not, politically, if he's telling everybody to cut and then he puts millions of dollars into something new, people are going to say, that's your priority over my department and my jobs. So I knew that we were destined to fail if I did that. My timing in that sense was terrible. So how was I going to pull this off? Well, I decided to take a different approach and tap my patient panel. Having been a cardiologist at MGH for 20 years, I had a lot of patients that I followed for a long time and had great relationships with, many of whom were business people in Boston, many of whom were entrepreneurial themselves. The former generation of grateful patients like to name buildings and elevator lobbies and things like that. The current generation is actually much more engaged, and they're interested in investing in things that they think make sense and where they're going to literally see, well, a return on their investment, not dollars in their pocket, but they'll see the product generated from their investment. So I thought maybe this would appeal to some of those patients, and I'm happy to say that this really did appeal to them, and they saw the opportunity and were willing to help me out with several $1 million to launch the lab. So with the money in hand, now it was a very different narrative when I went to meet with hospital leadership and present them with the idea and then with a bag of a few $1 million to say, I'm not asking for any investment from you. I'm just asking you to say, this is a good idea, we support innovation. That made it very easy, and how could the president of the hospital say no to that? So happily, they did say yes and allowed us to launch the Healthcare Transformation Lab. So we began building the lab in late 2013, about 6 months after I came back from Dartmouth, and the formal launch happened a little more than 2 years ago. So the first question was, how are we going to identify the problems and engage the staff to start innovating at MGH? Innovation was not part of the culture at this point because people had kind of given up on innovating. So the real question was, do we take a top-down approach or do we take a bottom-up approach? And we thought about this and we looked at the pros and cons. Many of the other innovation labs that we'd seen around the country had been top-down. UCSF decides they're going to innovate and they launched a lab. UPenn decides they're going to innovate and they've launched a lab. So the top-down approach, the advantages are you have the leadership buy-in, it's consistent with the institutional goals, and you've got clout and authority. The president, the CEO said this is important and we're doing it. So that's the upside. The downside is then the hospital gets to set the priorities for the innovation. When you come to a group and say, we're here to help, it's like, we're from the government, we're here to help. People's view is, no, you stay out. We know our business, you stay out of our business. So we'd be viewed as outsiders. And truthfully, we wouldn't really understand the problems in anesthesia or radiology because we don't live them. And we wouldn't know the political landscape within each department if we tried to come from the top down. The bottom-up approach, the advantages are we set our own priorities, we decide what's important for the lab, and then we can directly engage people on the front lines and get them to give us their ideas, to participate in the project, and really to have ownership in the process. If they own it, rather than us telling them what to do, maybe they'll be more enthusiastic and energize the process. We also felt that we could then focus on fundamental problems, the problems that people on the front line say are problems, rather than us deciding what we think are actually problems when they don't really believe that they are. And it's very non-threatening to the staff, or at least much less threatening, when you come and join them at their level rather than talking down to them. The disadvantages of this approach, though, there's a lack of a hospital mandate, and while not threatening as in threatening from above, it does threaten people from the side. So lower level managers who say, you're moving in on my turf. I oversee this clinic area. Why are you coming in and trying to talk about how we should do things differently? But in the end, looking at the two, we felt strongly that while other hospitals had gone top down, that the most strategic approach for us would be to go from the bottom up. And that's the way we went with the lab. Now, the second big question we faced was, do we start kind of as a hospital-wide MGH Healthcare Transformation Lab, or do we try to start within the heart center itself? And ultimately, we decided we would start within the heart center. Now, it helped because I was a cardiologist, and then my co-director happened to be a cardiologist as well. So that was one reason to start there. As cardiologists, we knew the problems, and we could design the solutions probably better than we could in other departments. We also understood the operations. We knew the administrators. We had social capital with our peers at all levels so that people would do us favors to try to get things jump-started. Now, heart conditions happen to make good innovation targets. There's a huge opportunity in cardiac, perhaps more than, say, in rheumatology as a place to start. Heart conditions are high impact. There's a big impact on health, but a big impact on dollars. Dollars for the healthcare system, dollars for the hospital. They're common problems. There's a high volume of inpatients and outpatients, so you can conduct experiments with numbers that are adequate to have demonstrable outcomes. And then things are very quantifiable in cardiology. There are lots of tools to measure things. So if we can do it here, at least then we have the best chance to have success early on. So we decided we would start within the heart center rather than try to do too much too soon. And readily defined outcomes and frequent events. So thus the Healthcare Transformation Lab was built, and this is our team. One of the key members of the team is Julia Jackson, who's our managing director. She's absolutely fantastic, and she really oversees the operations of the lab. And having a very talented person in that role is absolutely essential. Malik Majmudar is the associate director, so he's a cardiologist. Ami Bhatt and Aaron Aguirre are two of those part-time people who spend most of their time in the performance engine and part of their time in the lab. We then have three project specialists and managers, and then in the upper right is one of the other keys is we have the buy-in from one of the hospital VPs. So the VP that I built a relationship with over 10 years in the Heart Center, who really trusts me in what I was trying to do, agreed to take this on. And then so politically, she's got my back when I need to do difficult things for the lab. She's there to help me get them done. And having a champion like that, I think, is absolutely key. It's one thing to let you do it. It's another thing to champion the effort. So the first thing we wanted to do was create our vision. What really is the purpose of the lab? And it's pretty simple: to improve the value and experience of healthcare through collaborative innovation. So there we're not just focused on value. We really want to focus on experience, and it's value and experience for both the patients and the providers. We didn't want to improve things for the patients and make the providers miserable. That wouldn't get us anywhere. We wanted everybody to feel better about the healthcare system when we were done. So it's not just value, it's experience. And then through collaborative innovation. We thought collaborative innovation is going to be key to making this successful and sustainable. In terms of the goals to achieve the mission, it's one, to serve as a venue for like-minded, passionate people to collaborate on disruptive ideas to improve healthcare. We didn't want it to just be us. We wanted to draw people in from all over the hospital to work with us, and in fact, other groups as well around the hospital to connect with us so we could be a hub. And then to develop, validate, and implement innovative solutions to the challenges associated with traditional methods of healthcare delivery. So this was not only about devices or gadgets or things like that. It was any novel method of tackling the problems we deal with in healthcare. So one last challenge we had was kind of setting the priorities. There's a group across town at Brigham and Women's Hospital that is called iHub, and they're also doing innovation. But what they're focused on is all about connecting with companies and developing things that are going to spin off as startups. So many hospitals, including them, are focused on intellectual property startups and partnering. Now, the hospital leaders and the leaders of these programs see this as a potential source of revenue. So the hospitals are thinking, great, we can make money. And the leaders of the programs are thinking, we can sustain ourselves based on this. That's all well and good to talk about, but the fact is successful, profitable spin-offs are actually rare. So if within 5 years you need to be sustaining yourself on spin-offs, you're going to have to be very lucky. Because even if you spin something off, it's not going to be generating big dollars that come back to you that quickly. So that's just not really realistic. The second thing is this whole approach distracts you from the day-to-day innovation that I think is essential to happen in a hospital, particularly if you're looking to improve things for your patients and providers rather than for your bottom line. So we decided that we would go the other direction and narrow our focus. Our primary goal should be to improve the value and experience of healthcare for patients and providers at MGH. We are not going to solve the world's healthcare delivery problems now. Our first goal is to solve them for ourselves, because if we can't solve them for ourselves, we can't claim to solve them for anybody. So let's just focus on our own house and fix things here. If we can then disseminate our ideas to other programs, that's terrific. We'll be thrilled. And better yet, if we can generate IP that leads to some return for us, that would be fantastic. But those are not our primary goals. We've got to focus on what we can and should be fixing at MGH. And this was a little bit radical, and it took the hospital leaders a little while to get over the fact that we weren't trying to drive IP, but I think in the end, this is more true to what we hold as core beliefs in the lab. And one of the first important things I think was true at day one and is true today is we understood the risk of failure. The hospital is not paying for this yet. It's paid for through philanthropy, and we have to deliver in the end if we're going to get hospital buy-in. Even more importantly, we've seen other innovation groups at MGH and elsewhere in Boston that have failed. And the fact is, innovation teams in general fail the majority of the time. So if failure is a high risk, you've got to do everything you can to lower the risk of that kind of failure. So we were very deliberate when we launched the lab, not to be idealistic and naive, but to think about all the problems that might stand in our way and to tackle them as best we could. So as we looked at it, we saw 7 kinds of problems that we were going to encounter. The first is the culture at MGH. AMCs, academic medical centers in general, don't support innovation the way they're designed. They love tradition. That's not the way we do things, is what you always hear. Their record of success speaks for itself. Certainly at a place like Mass General, we're #1. That kind of success is hard to argue with. And then there's this thing called the status quo bias. People faced with alternatives they should objectively prefer disproportionately favor the status quo because it's familiar and comfortable. They don't like to change. And therefore, if you come in and talk about change without showing them why they should do it, they're not going to do it. Doctors of all people especially like their independence and resist changes that dictate care delivery. I'm the doctor, I know what's best, don't tell me what to do. That's a lot of obstacles in the culture. So how did we want to change this? We wanted to foster a culture of innovation at MGH, and I'll talk a little bit about how we did that. We wanted to get people to anticipate the future. What does the future in 2020 look like? What's the patient care experience? How would a doctor be functioning in the office or with the EHR 5 years from now? And how will that be different from this? And if we agree that that's the goal, we have to start moving in that direction. So let's agree on what the future should look like. We also want to focus on preserving the traditional goals. Nothing's wrong with tradition. What's good about the tradition is the goal, the patient care, the doctor-patient relationship. We don't want to threaten that. If we can find more efficient ways for you to do things, you'll have more time to talk to your patients rather than more time facing the screen. So if your goal is preserving that relationship, we can help you with your traditional goal. We wanted to emphasize the value of innovation and emphasize the value not just for the patient, but for the provider. There's value for you if we innovate. And encourage a willingness to disrupt the status quo even when the performance engine seems successful. It's successful today, but is that sustainable? So, you look at the new CEO of Kodak in 1989 who said he'd make sure to stick with the core businesses of film and photographic chemicals that made the company great. What a terrible decision. He was looking in the past, claiming, I know how to take care of things. That was the wrong approach. Compare that to Jack Welch in 1997 talking about GE and said, I take absolutely no comfort in where we are today. So a forward-thinking CEO, not looking to the past, but looking to the future. And we kind of emphasize these two statements to people, saying, yes, we may be great today, but look at what happened to Kodak. The second is the fear of failure. And now this is particularly true in medicine as opposed to some other companies. Hospital and departmental leaders don't accept failure well. They equate a project's failure with a team or team leader's failure. Your project didn't work, you didn't do a good job. As a result, particularly administrators choose only small or safe incremental changes because that way they know it will work, it's not too dangerous, I won't get in trouble for doing it, and that's never going to allow innovation to occur. Doctors don't like to fail either. If you think about it, most of the trainees during their training, they're required to follow the norms. You do exactly as you're told and nothing else, or you won't succeed. Moreover, as professional surgeons, for instance, your goal is to succeed in your work. Failure is humiliating. If something goes wrong, you're in trouble or embarrassed. That kind of culture makes it very difficult to break away from the standard way of doing things. So how do we tackle the fear of failure? Well, leaders have to acknowledge failure as a price of doing business, recognizing that when teams have performed well, teams can perform well even when the innovation itself fails. Therefore, you can take a risk and we won't judge you for it. Google says the moment you stop taking risks is the moment you get left behind. So we have to encourage risks as long as they're well thought out and calculated. And we have to reframe failure as learning. You didn't fail. Edison said, I have not failed 1,000 times. I've successfully found 1,000 ways that will not work. We don't view it as failure. You experimented. You learned from your experiment. Let's move on. Similarly, we need to get away from the idea that experimentation is safe. In our center, and I know a lot of other centers, they don't really like to experiment with innovation. They just want to have perfect innovation. So you plan it out in advance and make sure that it works. And therefore, innovation gets evaluated by the standard metrics of success. It's either a success or a failure. If it's success, you simply put it into daily operations. If it fails, you abandon it and you claim, we tried that, we will never try it again. And that stifles any further innovation when someone says, well, we could fix it and try it a different way. No, we tried it, it failed, we're done. And then leaders, of course, get judged based on all of this. So that's not a good way to experiment. What we need to do is introduce experimentation as part of the process. Think of it more like the lab bench rather than the clinic. So innovation should be viewed as disciplined experimentation. An experiment is successful if it answers questions, leads to refinements, and prompts the next experiment. So you don't abandon it, you refine it and you try it again. So Google says strive for continual innovation, not instant perfection. That is too high a bar to say if we're going to innovate, it has to succeed, because who can do that on the first try? And then you've got to rely on rapid cycle innovation or iteration. Google says our iterative process teaches us invaluable lessons. It's much better to learn those things early and be able to respond than to go too far down the road or the wrong path. So you've got to try things rapidly and quickly learn the lessons so you can tweak it. Don't carry on a 6-month experiment and then find out it didn't work and you've invested too much time and resources. The fourth problem is kind of an easy one that we all see every day: inadequate resources, whether it's lack of leadership, lack of administrative support, because it's not viewed as important or productive, lack of time, people's time. Expecting staff to add it to their regular jobs is not realistic. Lack of funding, We know it's one of the first things to get cut, lack of dedicated space for this work to take place. And because of this, even good ideas will often get no traction. So you've got to do just the opposite. You've got to commit dedicated resources, which means protecting time. It may mean paying people for their time doing innovation, which is what we do. Create a dedicated team of full-time staff who can focus on innovation. Provide the administrative support for that staff. Provide space for their interactions and collaborations. And then funds to launch them and sustain them. And you've got to try to view that as an investment in the future. It can't be viewed as a cost. It has to be viewed as an investment. And all of this will make you ultimately more attractive to industry partnerships, not right at the beginning, but later when they see that your institution is investing and protecting innovation, it'll make it more attractive to them. Fifth is lack of engagement and diversity, and what I mean here is often people think what you need is a big innovation guru. Just get a guy like this, put him in an office, tell him to innovate and solve our problems for us. And the reality is you really need engagement and diversity within your community if this is going to succeed. You should never happen behind closed doors. It should be an open process. And it should have a dedicated team that leads it but does not own it. The moment people feel the team owns it, they're going to see it as foreign and they're not going to want to participate. I think that collaboration is key. And then you need to promote this culture throughout the organization so that everybody feels engaged and it's not just a dedicated group. So emphasize collaboration and inclusion. And in our view, it's not just about the doctors. It's about everybody. Nurses, techs, administrative support staff. We want everybody in because the more people who are in, the more ideas we'll get and the more people will be willing to experiment and work with us. So we welcome ideas from everybody along the way. And we try to provide a forum for people to discuss these ideas and feel like they're going to be heard. The sixth is a simple one, the belief that innovation has to be big and exciting and dramatic. You know, launching a new Dreamliner is very innovative, but you know, launching a patient navigator app is much less glamorous but impactful. So innovation doesn't always have to be big and attention-grabbing. And then finally, and perhaps most importantly, is the lack of implementation. So some people think that generating the idea is all it takes, kind of the Field of Dreams quote, if you build it, they will come. We all know that if you build it, all you will have done is built it, but no one will come. So not having a system to follow through with implementation lets ideas wither on the vine. You need a well-defined and widely understood process to turn things into reality. Again, best managed by a skilled, dedicated team with project managers, administrators, data managers, and the resources to support them. All of those things are necessary for implementation. So having identified the 7 obstacles, we set out to try to tackle them directly if we were going to succeed. So we did this by introducing innovation into everyday culture with events, lectures, demos, and broadening of the conversation, and I'll talk a little bit about how we did that. We emphasized collaboration and inclusion every step of the way, and we continue to make collaboration our priority. And we practice iteration in what we do, experimenting, learning, modifying, and repeating. And we try to normalize failure. Failure is okay. Everybody should be trying to do the right thing, but you don't have to succeed on the first try. And then allocating the needed resources, the money, the time, and most importantly, the project support to see these projects through. And we've also focused on small projects as well as large. Our goal was to make sure we had deliverables at the end of the first year, because otherwise people will say, well, what have you guys done? You haven't really done anything. It's all smoke and mirrors. So while we do want to have long-term projects, bigger projects, we also know that we need to have quick wins and repeated wins so that we remain relevant and people continue to believe in us. And then, once again, making implementation our top priority. We can never let any good idea be dropped, a ball be dropped, because implementation wasn't carried out completely. So in designing the lab, we basically have 3 areas of focus. First is collaborative innovation, engaging our staff and bringing their ideas to the fore. The second is digital health, and then the third is validation studies. So I'll just go through these a little bit with you. So collaborative innovation really is about inviting and encouraging every member of the MGH community. In the first year, this was Heart Center. We've now moved to the broader MGH community to contribute to the process of ideation and innovation. Everybody can bring forward ideas and participate in the process, and really focusing on this bottom-up approach that I described. So to do this, right at the beginning, we introduced something called the Etherdome Challenge. And for those of you who don't know, the Etherdome is this operating theater at the top of the original Mass General Hospital building called the Etherdome. And this is where ether was first administered for a clinical surgery in North America. So it was the hospital's kind of big innovation. And unfortunately, we look back fondly on how innovative we were in the past. So no better way to kind of reflect on the importance of innovation than looking at something so old and thinking forward to the future. So the Etherdome Challenge is an open innovation contest to tap into the collective knowledge, experience, and creativity of the Heart Center staff to transform healthcare. And it was carried out with guidance from the Crowd Innovation Lab at Harvard Business School, a group that has expertise specifically in how do you engage your staff. Not only did they help us design it, but they actually monitored the process and did research on it. And just in April, they published their first paper on the process and how it unfolded. And we had various incentives for innovation, for submitting ideas and winning, to see which kinds of things motivated people the most, so that we could learn from it for the future. And the answer to all that is iPads. People want iPads. They'll do anything for iPads. So what happened in this process? We asked people to identify pain points and potential solutions. We got 138 idea submissions. And ultimately, we submitted those to crowd voting. So 305 people voted on these 138 ideas, basically ranking them in terms of how important do you think this is, how solvable do you think it is, et cetera. Of those, 29 rose to the top, and we submitted those 29 to expert judges to talk about how realistic it was, what kind of resources would this take, would it be something we could really implement. And then ultimately, we ended up with 6 winners of this competition. So I'll show you the 6 winners in the first year. 3 of them were provider-facing, 3 of them were patient-facing. Just to give you an example, the one on the bottom on the left, the cost to cath was submitted by a nurse in the cardiac catheterization lab who felt that we could save money if we educated people about what each item in the cath lab costs, every catheter and every device, so that people could make better informed decisions. And we actually were explicit about what were the advantages of one over the other. And through that process, ultimately, they saved $300,000 of the cath lab budget last year. So it was a great project. It actually got everybody very excited, and they started to use that same approach to reducing other costs in the cath lab as well. So great because of the culture change and the outcome. On the right-hand side, in the middle, the Visit Navigator app. This idea was for patients coming in for multidisciplinary visits for complex care. This was for our heart valve program when patients were seeing a cardiologist, a cardiac surgeon, getting a CAT scan and an echocardiogram all on the same day, and they had to move around the hospital to keep the appointment straight and to guide people through wayfinding was essential, and so that's how this was proposed. Those were 2 of the sample projects from the first year. So good things that touched a lot of people, both patients and providers. The Harvard Business School found that the participants had great things to say about the program. We wanted to know, was there a real culture change? And there was. It enables bottom-up innovation contribution, promotes a sense of community, systematizes idea contribution, creates a sense of ownership and engagement, facilitates organizational exchange of ideas, and spreads innovative thinking. And we were really so pleased with this because our hope was that we could change culture, and we really saw people saying that they felt very good about it. They saw this as a way that innovation was something that was valued institutionally. A second kind of collaborative innovation that we instituted was actually across the river with our neighbors at MIT. MIT has a program called Hacking Medicine, which does hackathons, but really focuses on nurturing undergraduate and graduate students in their innovative thinking and to bring them together in collaborative teams to try to advance an idea and turn it into a viable product that could then potentially spin off into a company and innovate in that way. What they're really good at is the stuff in the classroom and with hackathons and in helping to plan what a business should look like. But the problem is these people are designing their innovations in isolation. They're not engaging the providers. They're not iterating. And so by the time they find out that there's a problem with their idea, they've gone well down the path. So our view is that if you're going to get to an incubator and an accelerator and get funded and maybe bought, you need to have a team that helps you figure out what lies in between. So connect with the hospital, connect with experts, connect with nurses, and iterate as you're thinking about the project, as you design your prototype, as you try it out, so that you'll stand a much better chance of being viable in the end. So this is what we call co-create with MIT. We had a first round last year with 2 winners, and this year with 1 winner, and those projects are all moving down the pipeline. So the second thing we do, the second area of focus, as I mentioned, is digital health. I think that's probably familiar to most people, what kinds of things are in digital health. But some of the things that we're working on specifically is using mobile and digital devices to better engage our patients and to monitor them at home between visits. A platform for secure texting and blogging among patients, care team members, particularly in the hospital, so that you all know what's happening during the course of the day. You can't actually get it from when you read the chart. In fact, it's even harder to now, more than ever, with an EHR, because people don't do anything until they write their formal note at the end of the day. So during the day, you don't know what's going on. But this way, the team can be communicating. It's more timely, more effective, and much more inclusive. Everybody knows what's happening with the patient. Better, more intuitive displays of data, whether that's in the office with your electronic health record or in the ICU with all of that ICU data. Telemedicine, not so much for the traditional approach, but for connecting to either remote locations or places where it's hard to get experts into. Mass General Hospital owns the hospitals on Martha's Vineyard and Nantucket. Traditionally, we have flown a cardiologist there once a week or every other week and back. That is incredibly inefficient, and it's also not always the right cardiologist. Much better to have a nurse practitioner on the island who can evaluate the patient and do a physical exam, and then you connect via telemedicine and you help make the decisions. You can even use an electronic stethoscope to listen to the patient's heart. But to be flying a doctor back and forth for a handful of patients does not make any business sense. So use telemedicine to accomplish that goal much more effectively. Then you can bring the doctor there when the doctor's needed and at a much lower cost. E-consults is a method of getting an expert consult without the patient ever having to see the doctor. It takes less time, it's less expensive, much more convenient for the patient, and much more timely for the consulting doctor. Multimedia tools to improve patient and provider education. Cameras in the OR to let the surgeons teach people what's going on. Multimedia in the office to help educate the patients and their families about their disease. And then the exam room of the future is something I mentioned to some of you earlier, trying to redesign the patient-doctor interaction to be more efficient, more patient-centered, and have patients learn more and understand their disease better. The validation studies, as you know, there are tons of devices and apps out on the market today, everybody trying to jump into this space, most of it designed for the worried well. Some of it, though, really does have an application for chronic disease management, but the question is, do these devices actually do what they say they're doing? And even if they do, even if it accurately measures blood pressure, weight, and everything else at home, does measuring that lead to a better outcome? Does it save the system money, or does it simply cost money because you're spending more time reviewing this data, or worse, it's giving you false alarms and you're bringing patients into the emergency room when they don't need to? Some of these things have actually driven up costs when you've done experiments. The companies don't always want you to do an experiment. They want patients and doctors to just buy them, but you don't want to buy them if they're not going to help, or worse, they're going to lead to more costly or ineffective care. So our goal is to try to take these things and test them. And do they have a role, and should we be implementing them? The one on the bottom right here is called AliveCore. It's an app that lets you actually do an EKG rhythm strip right on your phone and send it to your cardiologist. This has been great so far. So I think this one probably is worth the investment. Now, the validation studies, one thing we've discovered early on is we're a 1,000-bed hospital, but it's still difficult to do some of these validation studies in a timely fashion because you don't have enough patients or events to prove that it's worthwhile. So we thought if we're going to successfully do this, and if we're going to make ourselves attractive to industry to bring their devices to us to test, we probably shouldn't go it alone. So we've recently partnered with Stanford and Duke to create this Alliance for Digital Health Translation, specifically around cardiology. So they have innovation groups in their cardiology groups, and together, the three of us are trying to do this, and we hope that that will let us do it faster and make us more attractive to industry. Now, I'd like to give just one example of how we weave all of these things together. and something that might not be able to happen in the hospital or any hospital if there weren't a group that was trying to take the lead on this. So this device here is from GE. It's called the V-Scan, which is a handheld echocardiogram, an ultrasound machine. It was originally designed for the developing world because they can't afford the full echo machines and they can't transport the full echo machines. So they designed this handheld device. Then they used reverse innovation to bring it back to the United States. It's remarkably inexpensive. It's only about $8,000, so that's really cheap for a medical device, and it's actually very good. It takes a good echocardiogram. So when I saw this thing was coming out, I thought, this is going to be a game changer. Every doctor is now, the white coat is going to have a stethoscope and a handheld echo in the other pocket. And much to my surprise, no one bought this thing. I don't know a single cardiologist in the United States who uses this. GE, I thought, would have been shocked and worried about this. GE did nothing about it. Why was no one buying it? Because think about it. Do the insurance companies want to reimburse to do a handheld echo? If they reimburse, docs in the community, at least in the United States, are going to be doing this on every single patient because they can, and they'll be billing for it, and it's a way to just increase revenue. So the insurance company is going to lose money, so they don't want to do it. The hospital doesn't want to support it because, you know, if you're doing these in the office and it takes you 10 minutes, we won't be billing that $600 echocardiogram down the hall. We want the $600. Now, the doctors could do it for free. I mean, they could spend the time, but they're going to spend 10 minutes with a patient doing something they don't get reimbursed for? I don't think so. So no one bought it, no one does it. Well, that's ridiculous. This is something that the healthcare system would save a lot of money. It's a no-brainer. So how are we going to fix this? Well, we basically went to GE and said, if we can get our hospital to agree to experiment with you, will you give us the devices for free so at least we're not investing in the devices? Okay, they agreed. We went to the hospital and said, this is potentially going to reduce the overall cost of healthcare in Mass General Hospital. The state is watching you and wants to see that you are doing things to reduce the cost of care. Will you do this? We can assure you that every echo that's not done, every formal echo that's not done, will have a patient on the waiting list filling the slot. You don't have to worry about it. Will you pay for that 10 minutes of doctor's time to do the echo? They said yes. We said, then you can do a demonstration project to Medicare and Blue Cross Blue Shield to show that this isn't going to drive up cost, this will reduce costs. So everybody was happy, and now we're actually launching the trial with GE and the hospital to demonstrate this. We hope that it'll be effective. For GE, that's great, they can start selling their machines, but for us, we can start delivering care at the bedside the way we think it should be, which we can't do right now because no one's interested in touching a technology that's this good. So that's an example of the role the lab plays. So what's next for the lab? Well, as I said, we started in the Heart Center, and looking at how we did with the Heart Center, we did establish a record of success. We achieved visibility for the labs for some of our projects in this method of collaborative innovation. Lots of other departments now want to figure out how they can do this within their teams as well. And so we've now agreed to take on roles outside of the Heart Center, working with the Cancer Center, radiology, pediatrics, working with nursing, an incredibly important group politically at the hospital, and also talk about people on the front lines. And then with the Department of Anesthesia as well. What I didn't put up here, because it's not a hospital department, is our patients. We have a Patient and Family Advisory Council, and engaging the patients, I think, is important, not just for ideation, but if the patients are on board and they start telling the hospital leadership, we love this, we think this is great, they listen to their patients. The other thing we did is we moved physically out of the Heart Center into a new home that is not only out of the Heart Center, but it's physically outside the main hospital building in a hospital building a block away, which we felt psychologically was important. When you come to innovate, we want you to kind of leave your day job behind, take off your work hat, and come put on your innovator's hat and physically be apart from the hospital. So this is our own dedicated space called the Collaboratory, where we hope that people will come and hang out, spend some time, and work with us on projects. Now, one of the last things we felt we had to tackle was expanding the depth and breadth of our lab. We were a relatively small team, and some of the things we encountered tripping us up a bit in the first 2 years was technical expertise. We didn't always understand the technical problems or solutions that we were dealing with. We were having trouble getting access to all the data that we needed from the hospital and its computer systems, and then making connections for our devices to put information back. And then lastly was getting a seat at the table with leadership. If we were viewed as part of the heart center, then they wouldn't need us at the table. They would have cardiology administrators at the table. And we needed to get out from under that and have a seat at the table ourselves. Now, all this might happen in time, but we felt we needed to jumpstart it a little bit. So what we did was form a strategic partnership with two well-established teams at the hospital. One is the Mass General Physicians Organization. Basically, it is what it says. It represents all the doctors in the hospital and has incredible political power at MGH. We have a chief medical information officer who isn't working for the hospital, but works for the physician organization, and he's very interested, particularly in digital devices, and how it can reduce physician workload and burden. So given his interest in that, we thought we would partner with the physician organization, and they agreed. And then also with a group called MGH Lab of Computer Science, or LCS. Lab of Computer Science is well known. It started in the 1960s, launched by a guy named Octo Barnett, who was one of the first medical informatics specialists in the country. The group now does most of the programming of software at MGH and is very well respected and very effective in engaging with hospital systems. So we partnered with these two and then with the Healthcare Transformation Lab collectively to launch something called MLab, which actually just launched this month. Now what MLab is a group that's focused specifically on digital health solutions. So all the other things, the collaborative innovation and validation studies and things like that I'm talking about, those we do alone in the lab, but around digital devices or digital solutions, specifically things that we're programming or designing or trying to pick vendors from outside for, this would be stuff that we would do. So we kind of have a typical Venn diagram. Our areas of interest and expertise, the MGPOs and Lab of Computer Science, and everything that lives in the middle there, specifically about digital health, will be run by MLab. So it's just launched. We're hopeful that this will give us a little bit more political clout at the hospital. And this one got the hospital blessing, so we're eager to see this kind of help expand the depth and breadth of the lab. So to sum up my last slide, what's really important in innovating in a place like Mass General? Steve Jobs said it really well. Innovation has nothing to do with how many R&D dollars you have. When Apple came up with Mac, IBM was spending at least 100 times more on R&D. It's not about the money. It's about the people you have, how you're led, and how much you get it. And so for our lab at MGH, we're really all about collaborative innovation and helping people get it. And we feel that if we accomplish that and we have the people on board, we don't have to have so much of the money if we've got the people. And this is the approach that we hope will make the lab successful. So on that note, thank you all very much for the invitation, and I guess we have a little bit of time for discussion.
Thanks, Eric. That was an excellent presentation. You know, I like your comment initially that it's not a money problem, and I think in Canada, you know, we've got a largely public-funded system, and people feel because we don't have the private enterprise, you don't get the push for innovation. So like, you know, take banking, okay? If you went to a bank that didn't have an ATM or online banking, they'd have no customers. Yet we have this disconnected, undigital health system. But in the US, you've got, you know, more of a private system, but you're still lacking some of the innovation you're talking about. So do you think it's just the nature of healthcare that's an uninnovative industry, or are there other factors, or?
Well, I think the biggest challenge is that customers haven't shopped for healthcare the way they shop for everything else. I mean, you think about someone who's going to go out and buy a new refrigerator or microwave, they do more shopping. They shop by price, they look at consumer reports or things like that, they go online to compare. Then when it's time to go to the doctor, they just go to whatever doctor, or they ask their friend, what doctor do you go to, and they don't do anything more than that. Similarly, the data is not out there to compare one hospital to the next. And so as a result, they just kind of shrug their shoulders and assume that's it. So if anything, with a free market system in the US, we should have consumers driving this, and yet they don't. There's this kind of apathy around it. They spend more time looking at the price of their drugs, which pharmacy sells it for less or a lower copay, but they don't do the same thing with the rest of their healthcare. And that's part of the problem. The other part is that for a lot of these larger hospitals, there are enough patients so that they don't have to worry. If they were really competing for every last patient, they might be more innovative. But what I try to drive home in the message is, think long term. If you invest in kiosks for patients to check in or let them check in on their phone, you don't have to have all these people manning the check-in counter. Isn't that going to save you money? Yes, initially you're going to have to make an investment, but it will save you money down the road. And you know, maybe these people didn't go to business school, or maybe they didn't do well in business school, but they don't seem to grasp that concept. They're so averse to it. But you know, the airlines did it because it not only did it attract the customer, but it saved them a lot of money in the process. We're sending out reminder letters for appointments. That costs a lot of money. It would be much better for patients who opt in to just text them with a reminder, and then you get the response back. So if they can't make it, you know, and you can fill that with someone else. That's a much better system. And I'm hoping that in time, the hospital leaders will begin to catch on to this. But you're right. It's an amazing lack of forward thinking in the healthcare system.
I was curious, so you gave the example of GE that actually collaborated with you on testing, the validation testing. I found that very interesting. But I was wondering, how about the other vendors? Did you try, if you want to try, I don't know, if you had put a Fitbit up there, I don't know if you did validation testing on that, but did you approach other vendors, and were they willing to work with you in order to improve their device, or did they just see these validation tests as threats?
Well, so it's a good question. For GE, their device has been validated in multiple studies elsewhere. So really what we're looking at for GE is the use case. But for other vendors, so for instance, Samsung has a new handheld Echo that's even kind of sleeker than this one. It just plugs into your smartphone. So you don't have to have this whole extra box with the screen. The entire computer lives in the ultrasound probe, and you plug it into your smartphone, so there's less to carry around. That's brilliant. So for them, though, they need to validate it. They need to show that it takes adequate pictures. And so we said, you know, partner with us. We can do that because we figure if we do that part with you, not only do we show that it works, but then we can take the next step and say, let's put it in doctors' pockets and see what use cases there are, because we're already partnering with you. Fitbit is an interesting story because they do want to do a project with us. Candidly, in this room, I'm not so excited about it because Fitbit is great for healthy people. I'm not sure that our sicker population is really going to buy into it and that it will make a difference. They'll put it in their pocket or wear it, but they won't be walking a lot, and then what? What are we going to do about that? And I'm not sure that that will add a lot. So I'm willing to kind of explore it further, but I think we've got to find a more convincing use case before we invest time and resources in studying something that I think doesn't stand much of a chance for success, at least for that purpose. You know, maybe for other purposes. I have a Fitbit, but at least at this point, I'm a healthy person. But I'm not sure for hospital patients exactly how we're going to incorporate that.
I'm thinking of your 6 projects that you talked about earlier, and the 2 aspects that you've deemed to be important. That is innovation, first off, and implementation. I know a group here in town that works in mental health, and they had the same experience. They were able to achieve great gains amongst themselves, at least for 6 months. And then came the time of saying, how can we sustain this thing? And they adopted a formulation of something called implementation sciences approach. Have you been able to see in those 6 projects the successful move towards implementation after an innovation was put together?
That of course is absolutely the key in the end, is are these things sustainable? And what we're still grappling with is the initial implementation is very successful when our team is leading it. So we've, for instance, implemented a lot of the telehealth initiatives in cardiology because we're good at implementation. Now we have to hand that baton back to the cardiology administrators, and we're very worried about them dropping that baton because they're just not that interested in it. And if they drop the baton, ultimately, firstly, the project fails, but also it reflects on us. And so we don't want to carry the baton indefinitely, but we also don't want to pass it off if we're convinced it's going to be dropped. And making sure that people can sustain it is very important. And that's where I think getting more buy-in from hospital leaders and departmental leaders that these things are important, or being able to demonstrate the downstream added benefit. It doesn't have to be revenue generation or cost savings, but just better outcome, better patient engagement, better patient satisfaction, something. My view is what we have to do is make it such that people would be embarrassed to be the one who dropped it. Like the hospital navigation app, we're paying to design it, so we're going to invest the $100,000 or whatever to build the app. But once it's up and running and someone has to maintain it, our view is we want that to shift over to the hospital. And is the hospital going to say, no, we're not going to do that? Our hope is the hospital will say yes, because everybody will say this is a great thing and we need to continue this. But you're right. Ultimately, none of this will work if it's not sustained. And we don't have the answer yet. I think these projects are now only in their second year, and therefore we haven't gotten to find out how well they'll fare over the long run.
Last question.
Thank you again for the presentation. I just want to follow Brian's question about implementation and sustainability of everything. Just one question. Do you feel the need that actually you need kind of systematic approach for the implementation, or every project should be individual implemented?
I think it is good to have a systematic approach. The challenge there is every hospital is different, and then every department within a hospital is different. And therefore, I think one size fits all won't fit anybody, and that's our fear. So the reason we chose the programs that near the end there, I said we're working with the Cancer Center, Radiology, Pediatric Anesthesia, because what we want is a coalition of the willing. The departments who say, we're really interested in this, we want to work with you, we want you to help us with our projects. They've already identified themselves as departments where the executive leadership is engaged. Honestly, candidly, cardiology in that sense wasn't the best place to start. I mean, we started there with good reason, but our administrators are just not interested in it. And that's one of the reasons why we originally planned to stay in cardiology for longer, but we decided the first opportunity to move out, we would, because every time we talked about this stuff, they kind of shrugged their shoulders. They just weren't that interested. And therefore, I don't think that they're the right group to take these batons and keep running with them. So we're trying now to move as many of our projects out of cardiology and into the Cancer Center, because the Cancer Center is really excited about these opportunities. And so if we can work with people who say, yes, we will commit the resources and we will commit to implementation and sustaining these things, I think we stand a better chance. Then in the end, I think one day cardiology will look and say, wow, we ought to be doing this too. But they still don't get it yet. And that's been a problem for us. We thought they would. They don't, so we're just going to turn our attention to a coalition of the willing. I know there was one last one here, so.
Absent wealthy philanthropists, how might you get started?
I'm sorry, was it for?
Absent wealthy philanthropists, how might you get started?
Find some. I think the situation is probably different in every hospital, and certainly between our two countries. I think a hospital where there's a burning platform makes it much easier. And so if you take a look, I don't know how many of you know the Virginia Mason experiment. Virginia Mason adopted the Toyota production system to healthcare delivery, but they did that because they were going under. And basically it was either do something dramatic or they'll be out of business. And that's how they pushed everybody to adopt this system. So I think a burning platform helps a lot. Without that, I think you have to have leadership that's more visionary. Other hospitals have leadership that's more visionary. The hospitals that have launched these programs have leaders that I think get it. Unfortunately, I think being a #1 hospital and our leadership has been in place a long time, I don't think they get it. So I think that the group at Penn, the leaders are the ones who started this whole thing. The UCSF, the leaders started it, but at Mass General, they're very averse to innovation. So I think that in our kind of situation, I don't know how it would be possible without the philanthropy, honestly.
Well, that's great. Well, thanks a lot, Eric. And on behalf of the Telfer School, we'll give you a small token. 2 tokens. It went up. So Eric will be around. I think tomorrow he's going to meet the Telfer faculty in the morning. And then he's off, and we'll be in contact with Eric over time and continue to build the relationships again. A lot of the work you're doing mirrors some of the work, at least the collaborative innovation side that we're doing. So we look forward to collaborating and working together. Great. Thanks for coming.
Thank you all very much.
Yeah, good. Good talk. Well done.